You are listening to the Movement Therapy Podcast. Hello and welcome to another episode of the Movement Therapy Podcast. I'm your host, Ethan Miles, one of the physios at Movement Therapy, and I'm joined by our newest team member, Zoe.
Hello, Ethan. Thank you for having me.
Thank you for joining me, Zoe. Today, we're going to be talking about the back.
Great.
Back pain. It's the forbidden topic. It's the topic that everyone told me not to touch because it's too complex. But I'm going to touch it.
Great. Let's dive in.
Yeah, we're going to get straight at it. There's so much to unpack here. So I don't pretend to know everything. I don't know everything. And I don't want this to be an exhaustive list of do's and don'ts. It's not going to be a how-to guide. What I want to do is just provide a little bit of education around the back pain, different types, and I want to reduce fear in people's heads. So
Great.
To be able to just make this a nice topic that people can talk about without freaking out a little bit about it. So let's dive straight into a bit of stats. So I pulled this data directly from the Australian Institute of Health and Wellness.
Mm-hmm.
And specifically, we're going to look at the burden of disease.
Tell me some more. What's that?
So the burden of disease measures the impact of diseases and injuries on a population.
Yeah.
Really. So it combines the years of healthy life lost due to living with ill health with the years of life lost due to dying prematurely.
Yeah. Okay.
So it combines these two measures. So essentially, it's the difference between population's actual health and its ideal health.
Yes.
Where the ideal health is living to old age without disease or disability.
Yeah.
That's it in a summary. Now, I'm going to go through some specific stats and I'll put all this information and the links you can find to these specific databases on the show notes. So if you want any further information, jump down there. But let's go to the top 5 causes of disease burden in Australia in 2023. For a female perspective, dementia was the first.
Like that was the 5th most likely?
No, that was the first. That was the
that was the most.
That was the highest cause of disease burden in Australia.
Can I guess what the second one is?
You can have a guess. It's not. You could get it. It's.
I'm
very
second guessing myself. Heart disease.
Oh no, that was 5th.
What?
Yeah,
Second. I don't know. Tell me.
that's a good guess though.
Thanks.
Anxiety.
Oh.
Yep.
Yeah.
So that was second at 4.9% of the disease burden in Australia.
I don't
Guess
want
the third
to.
follows the particular theme of today's podcast.
Back pain.
It's back pain.
Oh my God.
Is the third highest cause of disease burden in Australia.
I don't want to say fun, but
Interesting.
That could be it. Yeah.
It was pretty shocking. I didn't realise this.
That's quite surprising.
That was pretty full on. Now, this is lower back pain, so any injury or disease associated with the lumbar spine. So L1 to L5, essentially the small sort of crook area in the lower back.
Yeah.
So now go to a male perspective. Heart disease was first.
So I was right.
What's second?
Back pain.
Back.
Oh, wow. There's a recurring trend here.
There is a recurring trend here. And that's why we're doing a podcast.
Thank God you're here to tell us all about it.
I'm here. I've got your stats covered. So again, some more numbers which might shock you. So 4 million Australians had associated back problems in the financial year of 2017 to 2018.
Wow.
So it's going back a little bit, but that's about 16% of the population back then. So that's heaps.
That is heaps.
4 million people have back pain. So do you have back pain?
Yes.
There you go. You're one of the 4 million people.
Do you have back pain?
I actually do today.
Oh, you're one.
I have played some tennis, so we're part of the stats. Okay, this next stat is quoted from the Australian Commission of Safety and Quality in Healthcare. It's a fun little document. Lower back pain is one of the leading causes of disability worldwide. So this is across the world. And in Australia, it is actually the top reason for lost work productivity and early retirement. The top reason in Australia. So that's huge. Now let's talk about the cost, because this is another sort of surprising stat. Well, unsurprising if you listen to the first part of this. In the financial year of 2021 to 22, low back pain cost Australia. Want to take a guess?
$4 million.
No.
Oh.
$3.4 billion.
Oh, that was very off.
You're off by a few zeros. $1 billion. $3 billion it cost just for back pain. Just low back pain specifically, not even thoracic pain or neck pain. It's literally low back pain. $3.4 billion. It is actually the second highest reason that people presented to the GP,
Wow.
and one of the top 5 reasons people presented to ED.
Wow.
Top 5. That's huge.
Easy.
So I wanted to sort of talk about this for a couple of minutes and explain why the fact that money is given to the wrong place. So at the moment, the money is being given to emergency departments and hospitals for this musculoskeletal issue for back pain. But really, it's wasted there. It should be coming over to the clinics, and it should be spent in a better way. Let me summarize that a little bit better. In the financial year of 21-22, the government spent $3.4 billion on back pain.
And that money, is that like the patient money, or is it?
So this is the cost that Australia is providing
Oh, wow.
to fund these problems. So, or corrections to these problems. So someone presents to ED, everything that they get in terms of management is paid for by Medicare.
Yeah.
So that's an Australian cost. So it's
Wow.
not private. It's the funding to government services.
Right. Okay.
Have you ever been to hospital for back pain?
No, not the back pain.
But you've been to the emergency department.
I have.
So if I reckon everyone listening to this will either have been or be associated with someone who has been in an emergency department of a hospital. So you kind of know what I'm talking about here.
Yeah.
So we've got massively long wait times. So as soon as you get triaged as not having a life-threatening problem, you back to the queue you go. You won't get seen for hours.
Yeah.
So the next thing associated with this is that you're not seen by a musculoskeletal expert. So not dismissing the qualifications of any of the doctors and registrars. They do an amazing job, but it's not their field.
Yeah.
So they do a little bit, obviously, throughout their studies, but musculoskeletal conditions specifically are not their field. So we don't expect them to have a lot of knowledge in these areas. So that's going to be one. Now, most of the time, hospitals will give you pain relief. That's kind of about it. You might not even get a scan if they're not suspecting a serious pathology here. So then most likely they're going to refer you to come and see physio or a chiro or some other health professional. So that's the hospital. This is not the best care for people with back pain, either acute or chronic.
Yeah.
So we're going to go into when to present to hospitals in our next episode for acute pain. But my point is that the money would be incredibly valuable in private clinics.
Yeah.
So we are the musculoskeletal experts. Physios, chiros, exercise physiologists, osteos. We train in assessment and treatment of all musculoskeletal conditions, including chronic pain, acute pain, doesn't matter what type of pain. We are the experts in that. What this money potentially could provide as well is better facilities, better equipment, bigger spaces, more staff, better training for staff, better access to training, further education, patient subsidies as well. So cheaper healthcare to enable patients to actually come and see us. Cheaper private healthcare, the list goes on. So what it would also mean is actually we reduce the load on the hospital system.
Yes.
And the
that'd be
emergency
good.
department, because they're smashed.
Yeah.
I don't think I know of one hospital that isn't smashed
Oh, no.
with their ED department.
Yeah, absolutely.
I don't reckon there's one. Even rural, regional, metropolitan, literally don't know any. So these places need to be preserved for trauma, for cancers, for neurological conditions, genetic conditions, general medical needs, not for musculoskeletal needs.
Yeah.
That's the main point about this. I could keep going, but let's not.
Yeah, I know.
Let's get stuck into this because I'm going on a tangent. But let's get back into why is it actually back pain the problem?
Because it hurts.
It hurts, right? But why isn't ankles or knees or hips or shoulders or wrists? Why are these not part of the stats?
Do you want my non-professional opinion?
I would love your that's why you're here, Zoe, to provide your non-professional opinion.
Is it because everyone's sitting down all day and they're sitting like I'm sitting right now with their legs crossed on their chair?
You look comfortable though, so that's the main
I'm very comfortable.
That's a really interesting question, actually, because we can't say yes or no to that. The one thing I want is I'll answer the question with another question. Well, with a statement, really. There is no such thing as a bad posture or a bad movement. That's gonna polarize a few people.
That's controversial.
It's controversial, which is why I said it a bit quickly.
Just so no one hears.
Just so no one hears it and they might gloss over it in the
Yeah.
back. But if you went back, I said there's no such thing as bad movement or bad posture. And what I mean by that is if the body wants to do a movement, it should be allowed to do that movement.
Yeah.
If it doesn't want to do a movement, it will tell you.
Yeah.
In the form of pain or discomfort.
That makes sense.
So in your position there, you're comfortable for the moment. We've been here for about 15 minutes,
Yeah.
right? In another hour, you are going to move from that position.
Oh, absolutely.
Because your brain will tell you that that's uncomfortable and you'll change position.
Yeah.
But you're on a wheelie chair, you should be able to do that quite easily.
Yeah.
Right? Now, if people sit behind a desk for their whole day,
Mm.
the actual sitting position is not a problem.
Yeah.
The problem is the fact that they're there all day.
Yeah.
And then they're there 5 days a week. And then they're there for 20 years.
Mm.
That's the problem. The time spent in these positions is the problem.
Yeah.
So don't necessarily think that any position is bad. Look at sleeping positions. Everyone sleeps in a different position.
Yeah.
I've got clients that sleep on their back with their arm hanging upside down, attached to the ceiling. There's such variable positions for sleep, but they're still sleep. And they
Yeah.
still wake up fine and they still live their life.
Yeah.
So I still hold strong to that statement. There is no such thing as bad movement or bad posture. There's just too much time in these postures. So if you sat perfectly, like I am, obviously, then I'm going to get uncomfortable in an hour because my body's not used to this and I don't like it very much. So no is the answer to your question. The time
short
spent-
answer, no.
and the short answer, very short answer, is no. I think the question was, is it sitting that caused that
Yeah.
question? Yeah.
Yeah, that was, yeah.
So no, I don't think it is. It's the time spent in sitting
Right.
is a contributing factor. Cause is a tricky one.
What else are the contributors?
So many things. These are the things. The variable is the important part, right? But this is why we're not getting answers, I believe.
Mm.
And the answer is so multifaceted that we can't solve this question with one physio talking into a podcast, unfortunately.
Unfortunately.
As much as I'd like to, I think
That would be
wonderful.
fun, but
And people, I don't think, would like that more because, why haven't I done it sooner?
yeah, good.
So I'm not going to solve it as much as I'd like to,
Unfortunately.
but we've got some insights,
Mm.
right? So let's break it down. The main problem here is that we don't have a structural diagnosis or a structural cause. So have you ever heard the term non-specific low back pain?
Yes.
So a lot of people have.
Mm.
We got taught it at uni, specifically as a name of a pathology or name of a condition.
Right.
Right. And what it actually describes is a cluster of conditions. It's a group. So it's not one thing. It's just several things together that are
Yeah.
causing this non-specific pain.
Mm.
But this non-specific pain is actually a cluster of specific pains
Yeah.
that are coming together. So we've got to break that down and actually find the cause of these non-specific pains because there's so much to finding out what is actually creating the pain itself.
Yeah.
So I'm going to go into the weeds a little bit here, but we've got to figure out the diagnosis in two parts. What we need is a structural diagnosis.
Yeah.
So when you hear this, and throughout the podcast, we're going to be talking about these two types of diagnoses a fair bit. Is what we do in the clinic, and I want to try and give you an understanding of why. Structural diagnosis is number one.
Yeah.
So that's the physical structure, right? So
Mhm.
the bone, the muscle,
Yeah.
the joint, the tendon, the what structure is involved in that movement dysfunction or the pain.
Yeah.
Cause number one. The next one is the functional diagnosis.
Yeah.
So it is what is the function or the movement that caused the structure to become like this?
Got it.
Okay.
Yeah.
So really it's just asking you why. You come in with a sore elbow, why? Oh, because the tendon's inflamed. Yeah, but why?
Yeah. What did you do?
Because I threw the ball yesterday. Cool. There we go. There's your functional diagnosis.
Mm.
Poor functional capacity in throwing. It's resulted in the structural diagnosis of golfer's elbow.
So the structure's who you are and the functional's what you do.
That's very good. I like that. That's why you're here.
I know. That's why I'm here.
That's fantastic. I want to tell you a story.
Summarize when you talk for 10 minutes in 4 words. I'm here.
Yeah, that was passive aggressive.
So yeah, story time. Please
Story
tell.
time. So when I was a kid, right, and I hope someone resonates with this because I feel like my sisters and I will come together on this point. This is quite a good one.
Yeah.
But I was doing homework on the family computer
Yeah.
right? Because we only had one back in those days.
Yeah.
Very long ago.
I was alive too.
Oh, good. You weren't doing homework at that time, though.
Probably not so
No,
bad.
you're probably just rolling around. So I was doing homework on the family computer.
Yeah.
Right. Now, I had the dial-up internet scenario going.
Yeah.
Now, I had a big assignment to do for science class.
Important.
It was a big spreadsheet. It was huge. I was very excited. It was a big presentation about space.
It's good.
I did something, not important, did something, and it deleted everything.
Oh.
Right? So, well, in my head, I didn't do anything.
Yeah.
Right.
What did you do?
I just blinked and suddenly everything was gone. The whole spreadsheet, I spent weeks on this. Anyway, in tears, I go to Dad because he was our tech wizard. And I go, Dad, where's my spreadsheet? And the first thing he asked me was, what did you do?
Yeah.
And I got really angry and I said, I didn't do anything, right? Quite aggressively. Anyway, he goes on this. He eventually, he brings it back. For
Great.
some, yeah, I don't know, even still to this day. Don't know what
Maybe like a Control Z moment.
Probably.
Do.
Yeah. Cycle bin, recover file, something like that. Anyway, that's not the point of the story. But the point of the story is that the computer itself didn't delete my work.
Yeah.
I deleted my work.
Yeah.
Right? I did something. I pressed something. I clicked something. I'll bring this back to the body in a sec.
Great.
Right? It's the same way that the body reacts. Right? When you're in pain, there has to be a reason.
Yeah.
Right.
Someone has to have deleted your spreadsheet
Yes.
of in your body.
The body doesn't delete the spreadsheet.
No.
Something has happened to delete the spreadsheet. Now, that something is utterly multifaceted. So, we'll talk about pain in future podcasts, but for now, it could be anything to do with stress, fatigue, sleep deprivation, diet changes, alcohol, injury, trauma. The list is endless.
Yeah.
But something has to have happened to have caused that. The
Yeah.
body doesn't just become...
Just decide.
Especially, I hear a lot of people coming into the clinic and they tell me they just woke up with pain.
That's usually my excuse I tell you when I've done
Exactly.
something silly and I don't.
Right. And then I go back and I say, Zoe, what did you actually do? And you say, oh, well, I don't really want to tell you this, but I jumped off a trampoline on the 4th floor and I don't know, something else happened.
It was on the ground floor.
Oh, sorry. It's close. Anyway, there's a reason.
Yeah.
Right. There has to be a reason.
Yeah.
So we've got to figure out what that reason is. That's our job. And then we fix the reason.
So you're like your dad in this scenario.
Yeah.
Yeah.
That's nice. Brings it back. And your job is to now just to pick apart my analogies
Pretty much.
and just sort of, but it's good. It's good. As long as you understand it, that's fine.
Yeah.
So we're going to go through the structural diagnosis now. So we're going to talk anatomy. I'm going to get sciencey. So can you point
I am ready. I did intro to anatomy and physiology
This is great.
at
This is
uni,
perfect.
so I'm ready to go.
So I need you to bring this back and make it so that people understand. Now, types of pain. I said I was not going to go through this. I lied. I'm going to go through this, but I'm going to do it very briefly
Great.
because there's going to be another podcast on probably each of these.
So just a little snippet,
Just a snippet, just a little
taste test.
Yeah, a little blurb. I'm
Okay.
excited for that podcast. We're going to probably get Andrew Darthweston, our chiropractor, resident educator, phenomenal. He's going to come up and
Exciting.
explain pain to everyone. It's going to be amazing. But for now, I'm going to give it a crack. So we're going to have 3 main types of pain.
Yeah.
Well, really, there's 4.
Let's go with 3.
We're going to go with 3. The 4th one's actually unknown. So we're going to kind of just put that in the pocket there.
That's like when you do a multiple choice quiz
Yes.
and the last one is all of the above.
Exactly. It's always that one, isn't it?
It is, but
'Cause- Yeah, I know.
you always roll your eyes.
So let's go through the first one. It's the most common one.
Yeah.
It's called nociceptive pain.
Nociceptive.
Nociceptive.
Great.
Okay.
And tell me about that.
So nociceptive pain is the most common cause of pain that we see in a clinic. So it's essentially a musculoskeletal pain. It's formed from mechanoreceptors in the skin telling the brain signals of things that have happened. So it's detection of threat. Right?
Great.
So nerves detect something. So you put your hand on the hot plate.
Yeah.
The thermoreceptors in the skin detect that it's hot. So the only way you can tell the brain to lift your hand off the hot plate is to produce pain in the area for you to do something about it.
Great. So nociceptive is body telling brain it hurts.
Body telling pain is a danger.
Great.
Then the brain produces the hurt. And then the body does something about it.
Okay. So body tell brain problem.
Yeah.
Okay.
So that's nociceptive pain.
Yeah.
Again, it's the most common. It's it's a trick. Again, we're going to get into the weeds here, but it's its own podcast. But I just want to pull you off into a little tangent for just a second.
Why not?
Because I've heard this really good fact.
I love a fun fact.
I do. It's a fun one. This is probably the funnest one you'll hear all day.
Okay.
We're born with 2 fears.
Can I guess that? I love doing the guessing.
Yeah, you can guess them. This is a good one because I'd had a go at guessing when someone was telling me this. I actually got them wrong. Actually, one of them I sort of got right.
Born with 2 fears.
Both wrong. One of them wasn't spiders.
I'm not scared of spiders.
I am.
So I know you are, but I'm not.
I just thought everyone had that innate fear, but apparently not.
Born with 2 fears. I was going to say bright lights.
Oh, that's not a bad guess, actually. That's a much better guess than I had.
Yeah, because
I said
spiders.
I thought everyone was scared of spiders. They're creepy.
They're not creepy.
So I like that. That's stay with that tangent.
Loud noises.
Wow. That's 100% correct. This is unreal.
Do you think I should maybe go?
Did you read my notes?
No, I definitely didn't read that bit. Do you think I should go on the chase or something?
I think the chase or like the millionaire hot seat. I think you'll win more money.
I could get that $14 billion.
That is, you could pay for the back pain for last year. That is phenomenal. I'm shocked. Anyway, yeah, loud noises.
Yep.
What's the next one?
Is it on the same kind of...
Sort of. It's a very common dream people have.
Falling.
Very good. Nailed it. 2 from 2. Jeez.
You gave me a clue, but I'll take it.
That's a pretty broad clue. That could have been anything. That was incredible. I'm very impressed.
That was quite a fun fact.
That was a good fact, right?
Yeah.
You're born with 2 fears. So why do we have other fear? This is the thing. Fear is learnt.
Yeah.
Okay, so spiders. Something happened to me as a kid to hate spiders. Don't know what it was, but fear is learnt. So fear, a lot of people and a lot of my clients, a lot of clients we see through the clinic have a fear of pain.
Yeah.
So pain is that sort of taboo subject that people want to avoid, but there is nothing more important in the human body than pain.
Yeah. Telling me something's going on.
The brain and the heart might be pretty important, but if you don't have pain, you can't detect threat.
Yes.
So let's pull you again on another little tangent.
Here we go.
I seem to do that a lot recently, but it's quite fun. We'll play on. So diabetic neuropathy.
Yes.
Is when the peripheral nerves, so the nerves on the hands and legs, start to die because there's too much sugar in the blood.
Yes.
So eventually you start to not be able to feel your foot, for example.
Not great.
Now, if you step on a nail and you can't feel your foot, you're not going to feel that nail. So you keep walking away. That might be weeks, months, probably not months. It'll probably happen before then. But that wound gets infected because you don't do anything about it.
Bye-bye foot.
Bye-bye foot. So then foot goes septic, it starts dying, and then they have to cut it off.
Bye-bye foot.
So that's because pain isn't present.
Yeah.
Now, if you or I stepped on a thumbtack or a nail, we would do something about it. And we'd stop walking on it for a bit to let it heal, and we'd cover it. No infection, we still have our foot. So pain is extremely important. Okay, back to the pain.
Yeah, back to it.
So nociceptive pain, that's number 1. Neuropathic pain, number 2. Nerves.
Yes.
So something irritating the peripheral nerve, which is the nerves in your limbs, or your central nervous system. So spinal cord and brain. Right. Neuropathic pain. Sometimes getting lumped into a term called radiculopathy.
Big word.
Big word. And essentially all that means is an irritation of the nerve that comes out of the spinal cord that runs down to your leg.
Is that like when you get like sciatica pain and that kind of thing?
Yeah, it could be. Could be. So that you get that sort of burning down the leg.
Yeah.
Yeah. So
or like when you bang your funny bone?
No.
Oh, but that's like...
That's a peripheral nerve.
Oh.
Yeah, because that's in your elbow. So the radiculopathy is from your spinal cord.
Oh.
And it's a nerve root that leaves the spinal cord and then travels down the leg. If there's an irritation in that nerve root that's just come off the spinal cord, that will send a signal down the leg.
Right.
I lost you.
Can you maybe explain it to me again, but like I'm 12?
Okay. So there's a big nerve in the middle of your back.
Yes.
There are little nerves that come off that big nerve.
Yeah, like roots on a tree trunk.
Exactly. So you've got the big tree trunk and then you've got the roots coming off the tree trunk. If something is irritating the root very close to the trunk, that might have an effect 2 meters down the root.
See, now it all makes sense.
Yeah. Oh, good.
Yeah.
There you go.
There we go.
So that's it. That's all. Think of a tree.
You could have just said that to start with.
Look, I'm so sorry. I just wanted to make it really complicated. So that's neuropathic pain. The third type of pain is inflammatory pain.
Yeah.
So a lot of people have heard the term inflammation, and again, they get scared. No one likes inflammation. That's why anti-inflammatories exist. Nurofen and Advil and all these things to reduce inflammation. But inflammation's good.
Yes.
We love inflammation.
We do.
Inflammation helps to heal.
Yes.
In fact, we can't heal without inflammation. So inflammation is essentially just blood flow with these chemicals in it that help kill infection and help heal tissue that's been damaged. And the positive effects of inflammation are tenfold. Excessive inflammation is where we get into trouble.
Yeah.
So if there's too much inflammation than what we require, then we start to get excessive swelling and joint restriction.
Do an inflammation podcast episode.
We're going to have to do one for each of those. Pain. It's going to be a fun one. I can't wait. I'm glad people can't see the facial expression because you really are looking forward to that one.
It's going to be like a feature-length film.
It's going to be a long one, I think. I hope.
We'll have to get like bean bags or something.
Yeah, some chips or some kind of halftime snack. Okay, let's bring it back to the back.
Yeah, sorry.
So go back to the nociceptive pain, right? Pain can be arising from so many structures in the spine.
Yeah.
So many in there. Let's just talk about the main ones. So everyone's heard of the disc, the intravertebral disc, right? Everyone thinks that they're these, movable little things that you can take in and out and they can slip. I'm just going to put another statement out there again.
Controversial again.
Yeah, I mean, another polarizing
Here we
one.
go.
You cannot slip a disc.
Well, then why do people say you can? Or
Don't actually know where it came from. But it is not possible to slip a disc. Discs don't leave their spot. They're so firmly wedged in there. Now you can bulge a disc, you can fracture a disc or crack it. You can extrude a disc. You can't slip it. So discs don't move. So I want you to get that out of your head. Right? Another one.
That's going to be a funny fun fact.
It's going to be my fun. God, I have so many.
Actually, no, the baby fear thing.
Baby fear thing, that was good.
Yeah.
I'm so surprised you got that, actually. I'm
Why?
still reeling from that. I mean, just the people I've asked have not got it.
Obviously not intellectuals.
They're not
like
intellectuals.
me.
So joints.
Yes.
The next thing is the joint between the vertebrae. So you've got the actual vertebral body. Right?
Yeah.
But then that has to articulate and join with the vertebral body on top of it and underneath it. So they have to have a joint. So obviously the disc is between the body.
Yeah.
But outside you've got little arms on the vertebrae and they attach to the other arms on the top of the vertebrae on top of it. You with me? Like building
No,
blocks.
I'm trying to think of a way to describe it in a easier way.
All I'm picturing is a baby on the ground stacking blocks.
Yeah, I was thinking like Lego bricks or something like that.
Yeah, it's cool. So you've got the main Lego brick with some arms hanging out of it.
Yep.
And you put a Lego brick on top of it with arms hanging out of it. Those arms have to touch each other.
Do you remember those monkeys? I don't know if you had them as a kid.
Yeah.
But their arms would hook.
Yes, the hooked arms.
And
Fantastic.
Yeah.
I
Can't do that.
don't know if that's very much like what I'm saying, but I like the analogy because I quite liked that game as a kid.
Me too.
I don't actually know what the objective was of it.
Hook all the monkeys together, maybe.
Is that it?
Anyway,
I just helped.
back on the highway. We've gone
Gone
off.
off again. There's lots of turn-offs on this one. Okay, so these are mainly called facet joints, but they've got a couple of names.
Yeah.
Zygapophyseal joint.
Nah,
Theory.
let's just leave that one.
We're going to go with facet joints. So, didn't think you'd quite like that one. So these are facet joints. Then we go to what we call soft tissue and hard tissue. Hard tissue, pretty easy one. It's bone. That's it.
Oh, duh.
Yeah, it's quite firm. It's quite hard.
Yeah.
Cool. Soft tissue, muscle, ligament, fascia, tendon, that sort of stuff.
Great.
Right. So these are the structures that can cause pain, or pain can be arising from them. And then you got the nerves, which we've talked about, the roots from the tree trunk. Cool. The only way we're going to look at these structures is with an MRI, right? Or definitively. All the structures that I've mentioned will show up on an MRI.
Great.
I'm going to go on a little tangent here again.
All right. We're hopping off the freeway again.
We're hopping off. This is going to be a good one, though. I'm quite passionate about this one. So we hear so much from scan reports, friends, relatives, I've blown my disc out, or I've ruptured XYZ, or, my disc is sitting in the corner of the room somewhere, because that's
I've slipped a disc.
Thank you, Zoe.
I was trying to think of what it was. I was like,
Well, you put it out of your head because I thought it doesn't exist. What I want to try to get through is that you cannot diagnose pain from an MRI scan.
right.
So let me go through that again. The scan, the MRI, is just a picture,
Yeah.
a series of pictures,
Yeah.
right? And it's just a snapshot in time.
Mm.
So you can't tell. Here's an analogy for you. When you say a picture of a door,
Yeah.
can you tell whether it will open or close. If you
No,
see a
you
picture of a
can't,
door,
but you can assume.
right, here we go. We're on. This is it. This is the whole thing.
Yeah.
You're assuming that the door can open.
Yeah.
Right? You can't see behind the door.
Yeah.
You can't see the hinges, the quality of them.
Can't see
you
someone's
can't see
holding it on the other
Someone's
side.
holding on the other side. You have no idea if that door will open. You just know that it is a door and it looks pretty good.
Yeah.
So you're making an assumption based on the picture. That is what your scan is telling you.
Yeah.
So someone, a radiologist, is looking at your scan who doesn't know you, who hasn't seen you clinically, doesn't know what you had for breakfast, or that you've had 6 sleepless nights in a row, is looking at your scan and going, yep, he's bulged L3, L4 disc.
Yeah.
So that is now giving you a lot of things, and you can take that and run with it. And I've got a lot of people who come in and I ask them, what's wrong with you? Or, why'd you come in here today? And they tell me I've got a bulging disc. And that's what they tell me. They don't say I've got back pain. They say I have a bulging disc.
Right.
Right. Now, you and I, Zoe, we might have bulging discs.
We might.
And we might not know it. But we don't have pain.
Yes.
So what we do know about MRIs definitively is that you cannot tell from an MRI what is causing the pain.
Yeah.
Back to that. All we're doing is making an assumption based on all the factors. So the radiologist is making an assumption. I'm making an assumption based on the clinical factors of what you tell us, your experience, as well as our actual assessment. As soon as you get into that room and start talking to me, or even if you're walking from the waiting room into the room, I'm making an assumption as to what is going on.
Yeah.
Because I can see you're walking, I can see, and obviously I'm going to ask questions and talk to you about what's going on. I'm going to put some diagnosis in my head and I'm going to start figuring some things out. And then we're going to go on to an actual test and sort of break them down. But there's so many scary words on scans. And
oh, God, yeah.
you can't, right? So, I've already mentioned a few of them: bulging, herniation, osteophytes. We're talking ankylosing spondylitis, spondylolisthesis. I can keep going.
No, please don't.
So these are scary words, right?
Yeah.
But you can't even tell when these began.
No.
You cannot say this started last Tuesday.
Yeah.
You had this bulge a week ago. Unless you have a comparison scan.
Yeah. I guess the MRI is very objective way of just they just looks at what's there in that moment and it goes, yeah, this is this right now, but it doesn't actually look at the why, the what, the when, the how.
Keep going. It doesn't.
That was it. That's actually it. I don't have anything else. That was my
I think that was a perfect summary.
Smart thing of the day.
Exactly. So it doesn't tell you why. It doesn't tell you, just tells you what it looks like.
Yeah.
When you're lying down. It doesn't even tell you when you're standing up. So things change when you stand. Because gravity.
All it pretty much says is that's the door. It doesn't say it opened.
It shows you a shut of a door.
The frame's warped and it can't close properly.
Exactly. Now, obviously scans are very useful.
Yeah.
I don't want to sit here and go, don't ever get a back pain scan. We're going to do another podcast on acute back pain. And these are our medical emergency
These are our hospital ones.
These are our hospital ones. We're going to do a podcast on that.
Fun.
Because they do exist.
Yes.
They're a small portion, but they definitely do exist. So I'm not here to say don't ever get a scan or don't listen to what it says.
Or don't ever go to hospital, just to clarify as well.
Exactly. Yes, let's not revolutionize the wheel just yet. If you've got severe pain and you feel like you need to go to the hospital, go to the hospital.
Let's just keep going on this hamster wheel.
Yep. For now, what I want to get through to you is that the MRI cannot diagnose pain.
Yes.
Okay. The important part of that, if you have a comparison MRI, that is very useful. If you had an MRI a year ago, 2 years ago, 3 years ago, and then one today, it's actually very useful to have a look at both of those to see what's changed. Again, still can't diagnose pain.
Yes.
It just says, hang on, your bones are starting to grow in a different way, or your disc is starting to protrude a little bit more into the central canal. That might be an area we need to look at, right?
It just is like you're looking at the big tower, the skyscraper, but you're not looking at how it moves when there's a cyclone.
Exactly. So that's the main thing about the scan is that you can't decide what it is. You have to use our knowledge of movement patterns and assessment to be going, look, the MRI says this, the movement pattern says this. If we combine them, we can kind of hypothesize where the pain is coming from. And we've got a really good understanding now of that. So that's where I'm going to go with the MRIs. We're going to talk more about that when we go acutely. But for now, let's get back to the diagnosis at hand.
Back on the highway.
Structural diagnosis, functional diagnosis. We need to assess those two.
Yeah.
So unfortunately, the body's all connected. So that's the bad thing. because
Do you know what? I'm actually pretty glad that my body is all connected.
overall, yeah, it's pretty good. It makes my job really hard.
Oh,
If it was in separate parts, it'd be quite easy.
yeah,
But-
like a little Lego man. You can
Yeah,
just-
that'd be fantastic. Take them apart, just put them through the wash.
hands broken, put
Yep.
it back on.
Exactly. That would be super
Fun.
easy. But one area will affect another.
Yes.
And will. It's not even might. It
Yeah.
100% will affect another.
Yeah.
So the ankle you rolled 2 years ago will affect, well, that you didn't treat and it just got better without treatment. Yeah, I'm assuming a few people listening to this will sympathise with that.
Yeah,
kind of
potentially
story.
someone that's speaking in this right now as well.
Yeah. Maybe even 2 people who are speaking in this might sympathise with this potentially.
Goodness.
But we won't go there. If you rolled an ankle 2 years ago and you didn't really treat it but it just got better, that will affect how your tibia rotates because you're going to lose potentially movement in one area of the ankle
Yeah.
because of pain.
Yeah.
So you're going to avoid that pain. You're going to rotate your tibia a little bit. Now that tibial rotation is going to pull the knee somewhere that it doesn't want to go. So the hip is going to pull the other direction.
Yes,
Femur now is rotating the opposite way.
because unfortunately
The body's connected.
the body's connected.
Right?
But-
So the body needs to try and work as efficiently as possible. So it's going to try and compensate. So tibial rotation, femur rotation, now the hip's affected from your ankle, right? So now the pelvis is actually going to try and shift to open up the hip potentially. Now you've got a pelvis that is not unstable, but it's moving in a different way than it should.
and where are we now?
We're in the lower back,
We are.
the theme of the podcast. So the ankle that you rolled 2 years ago might actually cause your back pain.
There we go.
There you go. So again, that might polarize some people, but you can't really refute it.
No, I reckon
Um,
I will have a stern chat to anyone who.
I'll just refer them to you.
Yeah.
Yeah. Fantastic. I've got a few. I've got a list. So movement. I'm gonna plug us for a little bit. Movement therapy. We use something called the selective functional movement assessment, which is essentially a movement assessment that come out of the States under the Functional Movement Systems company. And this is a way of separating common movements into essentially the 10 head to toe. You've got neck, shoulder, back. So bending forward, bending backward, rotating, standing on one leg and squatting. So
Great.
you've got 10 movements there. And then we break out these movements into actually find if you can't look down to your feet in a good enough way, we break that out and go, well, what are the parts that are associated with that movement? And then we try and make it better.
Yes.
Easy,
Easy.
right?
You would
So
think.
it simplifies a very complex problem. But for an example, if you go down and touch your toes,
Yeah.
and then you have pain, right? And then you go bend backwards as far as you can, and
Yeah.
don't have pain, but it doesn't look very good. The movement doesn't pass its test. There's a few criteria that we use. What we're going to do is break out the pain-free pattern, so the pattern that didn't hurt, and I'm going to check out why you can't do that particular pattern. So whether it's the hips, the knees, the ankles, the shoulders,
Yeah.
spine,
okay.
I'm going to look at that in its individual parts and I'm going to find the worst one. I'm going to treat that. I'm going to treat it, improve it, and then I'm going to go back to the painful pattern.
Right.
And I'm going to see if you now can touch your toes without pain. That's the way the system works.
Okay.
Okay. So if it's done well and it's diagnosed correctly and treated well, it actually works really efficiently. It's a great tool. But
There's always a but.
there's always a but, and I'm really sorry to bring this up. It's not that easy, is it?
Unfortunately.
Unfortunately not. So this is where we have to use all the facets of the assessment. So we've got
Yeah.
to be able to use our clinical judgment, your story, your experience, maybe an MRI, the SFMA, the Selective Functional Movement Assessment. We've got to put all that together and we've got to figure out what the structure that's damaged or irritated or just angry, what structure is involved. Is it the bone? Is it the joint? Is it the cartilage? Is it the disc? Is it the muscle, tendon, ligament? The list goes on. And then what caused it? Was it the fact that you rolled your ankle 2 years ago? Or was it more than that? Was it further down? Was it the fact that you fell off your ladder when you were 16 or fell out of a tree? Or was it yesterday when you were picking up a pillow?
A lot more that goes into it.
A lot more that goes into it. But the last thing I want to talk about today,
Okay.
right, is fear. Because we brought it up in the middle and we had a nice little fun fact.
Is your biggest fear spiders?
I would probably say it is What are yours?
I don't want to say mine. It's really embarrassing. This is going to be another polarizing thing for the day.
Oh dear.
But I've gotten a lot better with it as I age.
Clowns?
No, tomatoes. Don't laugh. It's serious. No, like as a kid.
Like, I mean, there's a difference between just not liking something.
Oh, no, I've got like a shiver down my spine.
Fear associated.
Yeah, no, as I would, and I don't know why.
Wow.
But I would see one like cut open as a kid, tears.
Really?
Yeah. In my food, tears. A lot of times when I go to a restaurant, I'll tell them I have an allergy.
Wow.
Yeah.
So do you hate them whole, cut up? Is it worse when they're in a sauce? Is it?
I can do like tomato sauce.
Okay.
As long as, so when I lived at home, when I was a kid, my mum would make spaghetti bolognese.
Fantastic.
Stunning. She would drain the sauce.
Yeah.
Get any sort of chunk out of it, serve me mine, and then put everything back in and give it to everyone else.
I would pay you out, but my sisters would yell at me because I kind of did the same thing just with any like vegetables.
Now
fussy eater.
I can get like, if there's a spaghetti sauce with chunks in it, I can now use my own fork to get it out, but wipe it very quickly.
Wow.
But if there's a slice of tomato in my food, someone has to take it out for me, and all the little seeds and everything, and like the smell.
That's fantastic.
It's not fantastic at all. I'm way too old to be like this. Anyway, I'm also kind of scared of waves. Anyway, next.
Oh, it's good you live at the beach there, next to a tomato farm.
Anyway, let's jump back on the highway.
So we're going back. Okay, fear, right?
Scary.
So I've told you people have fear of pain.
Yes.
A lot of people have fear of pain.
Yeah.
I kind of do. I don't like it.
It's not nice.
No, I don't like it. But what I want to get through with this episode is that back pain doesn't have to be fearful if you understand what's actually going on. So one of the goals in our assessment is to actually educate you as to what is the cause of the back pain so that we can de-threatenize it and work through it.
I feel like when you have an understanding of it, it's a lot less scary.
Exactly. Reading Harry Potter, they say, Voldemort.
Yes, I know him.
You know him personally. You've got to say the name because the famous Dumbledore line, fear of the name increases fear of the thing itself.
Where are we going with this? Glad we got
I'm
there.
trying to just get another analogy in before the end of the podcast.
Yeah.
As many as I can. We're going to have an analogy count overall. I think there's going to be a fair few in this one. But it's exciting. It's fun. So fear of the unknown is a big one. That if you don't know something, it's way more threatening and scary.
Boo, hate it.
So this is what we want to try and do is we want to try and de-threatenize. I don't know if that's a word, but I'm going to use it. We want to try and de-threatenize your pain. So it doesn't mean we want to ignore it or we sort of assume that it doesn't exist. We definitely know it's there, but what it means is that we don't want to rely on scans. We don't want to rely on one potential thing.
Yeah.
We want to rely on as many data points as we can. So the assessment, the education, the environment, the trauma, whatever it was, we're putting all of that together, maybe with a scan, and we are going to diagnose. We're going to structurally diagnose, then we're going to functionally diagnose. You're always going to have those two things.
And you know what I'm criminal for? Not acknowledging it. Just going, it'll go away at some point.
Yeah. So we're going to talk about that in
another podcast.
So the chronic pain, right? That's not severe, but it just lingers, right? And it's sort of not enough for you to do anything about, but then 10 years later, it's still there. That's we're going to talk about that. That's its own podcast.
When we jump onto another highway.
And we're going to go into another highway. But for now, we want to remove the fear.
Yes.
From the pain.
Because
don't we mean removing the pain, we're just removing the fear from it.
Fear's not fun.
No. Pain's not fun.
Pain's not fun either.
So why would you want fear on top of that?
Why would you want pain plus fear?
Exactly.
You can just have pain.
So we want to understand the pain, understand where it's come from, and work in stages to get rid of it. That's the goal.
Yeah.
Our only goal. So it took us a while to get there, but we're here.
Climb the stairway to heaven. Heaven is pain-free.
Okay, so that's going to be our first overview on back pain today. Thank you. Hopefully you stuck with us. And if there's anything within the podcast that you want to clarify or want to discuss more, please reach out to me or anyone here at Movement Therapy.
Why don't you give everyone a review of the podcast? But
Yep.
I'm going to keep you on the highway. You've got 30 seconds.
Right.
Ethan's 30. I'm going to think of a really good name of that for next
Can
time.
we not do this every time, please? It stresses me out too much.
Ethan's 30 seconds of fame.
Okay.
All right.
Here we go.
3, 2, 1.
All right. So back pain is one of the biggest causes of disease burden in Australia. What we need to do is de-threatenize the fear of back pain and provide a diagnosis. We're going to try and get a structural and a functional diagnosis. Structure is dealing with structures, what is actually causing the pain. Functional diagnosis is why that structure is becoming like this. So what we need to do is assess, and we've got to look at the whole body to get a functional and a structural diagnosis, and hopefully de-threatenize the pain while also looking at potential scans, but not relying on the scans for the diagnosis of pain.
So that was 33 seconds. Close. Not bad for your first try.
Very sweaty.
You talked really
Yeah, I wanted to get everything out, but I jumped around a little bit. How was the review? I didn't know what I said, really.
I'm going to be honest, I didn't really listen too much because I was looking at the timer, but I think it was it covered all the bases.
I hope so, yeah.
Yeah.
Look, it's a bit of a shame, we do all this research and do a 50-minute podcast, and then you can review it in 30 seconds and go, that's actually all we talked about?
We talked about so much more than that.
Well, I really hope so. So we're going to go through, obviously, acute back pain, chronic back pain.
Yes.
We've had 2 sort of follow-up series, so obviously we're looking forward to those. But
I'm looking forward to talking about them. I'm not looking forward to having either of them.
It's not a requirement. You don't need to have them to be on the podcast.
Okay,
Allow that to be a co-host without pain.
Okay, great.
But any questions or concerns or anything you want to bring up or explain or have us explain, please reach out to us either online, through the website. You've got our Instagram and emails to all the clinicians there, or pop your head in and have a chat to us. Otherwise, we will speak to you in the next episode.